Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello everyone, my name is Brendan Nguyen. I'm a nephrologist and Associate Professor of Medicine at Royal North Shore Hospital in Sydney, Australia, and the George Institute for Global Health at the University of New South Wales. Welcome to today's discussion, Hot Off the Press, Emerging Therapies in Non-Diabetic Kidney Disease. And I'm joined here by my friend and colleague, Beatrix Fernandez. Hi Beatrix, how are you?
Hello, thank you very much for this invitation.
So today we're going to discuss new data from the European Renal Association Congress on emerging therapies for non-diabetic kidney disease. We're going to take a deep dive into the results from new clinical trials, and we're going to take a closer look at which patient populations might benefit most from non-steroidal mineralocorticoid receptor antagonists in patients with non-diabetic and diabetic kidney disease. So first, let's take a look at the current status of CKD care and some of the clinical gaps in management as they stand at the moment. So Beatrix, can you tell our audience how you see the current treatment landscape, in particular for non-diabetic kidney disease?
Yes, of course. I think the main problem here is that we've got a standard of care, which is SGLT2 inhibitors and RAS inhibitors. So that is an issue because we've got a residual renal function that we have to address and we have to control. So in my experience, in people with chronic kidney disease and no diabetes, we've got an unmet need. So we have to address this unmet need.
And Beatrix, I completely agree with you that many patients, despite the treatments that are available, still have progressive loss of kidney function. And we talk about this concept of residual risk. So what does residual risk and what is it and how do we define it?
Okay, residual risk is the chances that you already have after all the treatments available to go to dialysis, to go to end-stage kidney disease, or likely to die because of cardiovascular disease or renal mortality. And it's still very much to do in patients without diabetes.
And the main way that we assess this risk is really albuminuria, isn't it?
It is.
Yeah.
It is albuminuria. So it's a highly driver proteinuria. Albuminuria is a driver of decreasing renal function in the future. So if we are able to decrease albuminuria right now, then the patients will get better and these patients will not eventually die because of chronic kidney disease.
Sounds great. And in the past, historically, our therapies that have focused on reducing kidney disease progression have predominantly targeted hemodynamic mechanisms, right? So RAS inhibitors and SGLT2 inhibitors both reduce glomerular hyperfiltration or intraglomerular hypertension through complementary mechanisms of action. But we know that kidney disease progression is much more complex than that. It involves a range of other mechanisms of disease progression. Outside of the hemodynamic pathways of injury, what are the other drivers of kidney disease progression, particularly in non-diabetic CKD?
Kidney disease progression means inflammation. Kidney disease progression means a lot of inflammatory pathways. When you've got albuminuria, then you will have glomerular disease. And this leads to glomerular injury, but also tubular injury. And tubular injury will lead to fibrosis and to glomerular nephritis, and leading you to have end-stage kidney disease quite easily. This increase in pathways, or not only hemodynamic pathways, but also inflammatory pathways, will lead to increase the ability or the chances to develop end-stage kidney disease. So there are some other issues we have to address when we are in the hemodynamic effects, but there are many other conditions that can enhance, that can increase this chronic kidney disease or this decreasing of eGFR independently, maybe sometimes of age, of sex, of other conditions. Like inflammatory pathways means a lot, and we are, again, just right in the top.
So Beatrix, you've discussed the important role that inflammation and fibrosis plays in driving loss of kidney function. What are the main drivers of inflammation and fibrosis in the kidneys, vasculature, and the heart?
One of the main drivers is renin-angiotensin-aldosterone system. And this is the trigger for almost everything. When we are meaning renin-angiotensin-aldosterone system, it doesn't have to be deleterious. It is just a physiological pathway if you are living in a dehydrating moment or if you are in the middle of the desert. But then the problem is not the middle of the desert. The problem is the constant trigger and the constant increase of aldosterone. So it is a trigger for all the pathway behind it. And it will increase not only metabolic conditions, decrease in insulin sensitivity, that will increase endothelial activity, but it is also an aldosterone system overacting in lipid tissue. And this will increase glucose uptake, increase lipolysis, increase lipogenesis, and this visceral fat is also a trigger and a driver of inflammation. So it is a vicious circle where inflammation is present everywhere, and this is something we have to address.
And you talked about the role of aldosterone. I think we're quite rightly now finally recognizing that the role it plays, even when it's only subclinically elevated. We've seen at this Congress and previously that even subclinical levels of excess aldosterone predict GFR decline and adverse other clinical outcomes, highlighting the potential impact of reducing aldosterone production or its activity on the mineralocorticoid receptor could have in terms of kidney disease.
Definitely. Chronic subclinical increases of aldosterone levels, it is something that is chronically happening, and when it is chronically happening, you will be more likely to develop end-stage kidney disease. So let's go to take a little bit of a deep look in this role of non-steroidal MRAs in non-diabetic chronic kidney disease. And tell me a little bit more about the evidence supporting the use of non-steroidal MRAs in non-diabetic kidney population. What did we learn from the phenomenon in FIND-CKD?
Well, Beatrix, it's been a really exciting Congress here in Glasgow because one of the great opportunities we had was to present the main results of the FIND-CKD study, which, as you mentioned, evaluated the effect of finerenone versus placebo in patients with non-diabetic kidney disease. Now, we have seen in previous trials in diabetic kidney disease that finerenone, a non-steroidal MRA, reduces kidney disease progression and cardiovascular events, but it was unknown whether or not this drug could reduce adverse outcomes in patients with non-diabetic kidney disease. And this is why we did the FIND-CKD study. FIND-CKD enrolled 1,584 patients with non-diabetic kidney disease, GFR greater than 25 and less than 75 mils per minute, and at least 200 milligrams per gram of albuminuria, who were treated with a RAS inhibitor that was stable prior to enrollment. The trial randomized these individuals to finerenone or matching placebo and evaluated the effect of finerenone on a primary outcome of total GFR slope, which is the rate of GFR decline over 3 years. In addition to the primary outcome of total slope, we also assessed the effect of finerenone on a range of other outcomes, including the key secondary composite outcome, a cardio-kidney outcome that comprised kidney failure, 57% decline in GFR, heart failure hospitalization or cardiovascular death, as well as a range of safety outcomes, including but not limited to hyperkalemia and other serious adverse events.
So you really address the total population we are right now seeing in our outpatient clinics. And what can you tell me about the eGFR slope and the rest of the things you've been talking about?
Yeah, so to your point, Beatrix, this was a population that was generally representative of patients we see in routine practice. This was a trial done in 24 countries around the world. Mean age was 55 years, approximately a third were women, and about half were Asian. The mean eGFR was approximately 47 mils per minute, and the median urine albumin to creatinine ratio was 820 milligrams per gram. Almost everyone was on a RAS inhibitor, and the baseline use of SGLT2 inhibitors was 17%, although that increased during the study. And in terms of the primary outcome, what we found was that patients allocated to placebo lost approximately 4 mils per minute per year. So they were losing kidney function very fast despite standard of care. In the finerenone arm, this was reduced to 3.3 mils per minute per year, resulting in an absolute treatment effect of 0.7 mils per minute per year in GFR improvement. Now that might sound to you like a modest effect, 0.7 mils per minute per year, but what that translated to for the key secondary composite outcome, the hard clinical outcome of kidney failure, 57% decline in GFR, heart failure hospitalization or cardiovascular death, was a 23% relative risk reduction in this outcome, which was statistically significant. So what we saw was the benefit on slope translated into a benefit on the hard clinical outcome. In terms of safety and tolerability, finerenone was well tolerated overall, with no imbalance in serious adverse events. Hyperkalemia did occur more commonly with finerenone compared to placebo at 17% compared to 13.3%. But importantly, clinically relevant hyperkalemia events, such as those leading to permanent treatment discontinuation or hospitalization, were low overall at less than 2%. So what these findings suggest is that finerenone is likely to have an important role in slowing kidney disease progression in patients with non-diabetic kidney disease.
So that's very good. And we've been talking about the overall number of patients. The numbers speak for themselves. You will decrease the relative risk reduction, not only the milliliters per minute, but also the relative risk reduction for cardiovascular disease, for chronic kidney disease. But what happens in these specific populations we are very much aware of because nephrologists need a little bit more about glomerulonephritis. So what happens with these patients in glomerular diseases? Can you tell me a little bit more in detail about that?
Yeah, I think it's important to say that first, the reason why this is so important and we're talking about it is that glomerular diseases have historically had fewer treatments. And so this is a patient population that really we need to find better treatments for. And one of the unique aspects of the FIND CKD trial was that it enrolled 903 patients in the trial with an investigator-reported diagnosis of a glomerular disease. So this is 57% of the overall population. And this constituted 416 patients with IgA nephropathy, 215 with FSGS, 90 with membranous, as well as a range of other less commonly studied glomerular diseases. And about 80% of these patients had their GN diagnosed or confirmed on a kidney biopsy, reflecting variations in biopsy practices around the world. And what we found in these patients with glomerular diseases was that in those who were allocated to placebo, the rate of GFR decline was 4.2 mils per minute per year. But in those randomly allocated to finerenone, this was 3.5 mils per minute per year, resulting in an absolute treatment effect of 0.7 mils per minute per year. So identical to the overall cohort. And then when we looked at chronic slope, which is excluding that acute dip in GFR, there was a 1.2 mil per minute per year better GFR slope with finerenone versus placebo. There was a 42% reduction in albuminuria in patients with glomerular diseases from baseline to 12 months. And also for the exploratory composite kidney outcome of kidney failure or 40% decline in GFR, there was a relative risk reduction of 26% with finerenone versus placebo in patients with glomerular diseases. And importantly, these benefits were entirely consistent regardless of glomerular disease subtype. Didn't matter whether it was IgA, FSGS, or membranous, there was benefits across the range of glomerular diseases, and results were consistent regardless of SGLT2 inhibitor use. And so what these data suggest is that finerenone has an important role in slowing kidney disease progression in patients with GNs.
That is a very important question because glomerular diseases, as you already mentioned, are not very much open, and it is difficult to get good results. People lose a lot of GFR very fast. They are younger sometimes. So it is a massive problem for nephrology community. And if you can address this massive problem in nephrology community, that will be great.
And as you know, Beatrix, these are often younger patients.
Yes.
These patients are younger than the overall fine CKD population. They often are juggling work, young families, and the impact of kidney disease is considerable. So finding additional treatment options is really important.
Definitely. You've been covering fine CKD, you've been covering glomerulonephritis, but we know that we had previous randomized clinical trials in diabetic population. We've got Figaro, we've got Fidelio. So how do we address everything? How can we do all together? So what does it mean using finerenone in different situations, different populations?
Yeah, you're absolutely right in pointing out there have been 2 previous trials of the non-steroidal MRA finerenone in diabetic kidney disease. And so with fine CKD, we now have an opportunity to better understand the effects of finerenone across the spectrum of kidney disease. Diabetes, no diabetes, different levels of GFR, different levels of albuminuria, different patient characteristics. And so this was what we did with the Infinity program, which is an individual participant level meta-analysis of fine CKD with Figaro DKD and Fidelio DKD to better understand the effects of finerenone across the whole spectrum of kidney disease, and also to better evaluate the effects on clinical outcomes which weren't powered for in the individual trials like dialysis and transplantation. And what we found was that overall finerenone reduced the risk of CKD progression by approximately 24%. It also reduced the risk of heart failure hospitalization or cardiovascular death by 20%, reduced the risk of dialysis by 15%, reduced the risk of cardiovascular death by 18%, and all-cause mortality by 12%. And importantly, these effects were consistent regardless of the cause of kidney disease, diabetes, GFR, albuminuria, and SGLT2 inhibitor use. And so taken together, these data suggest that finerenone, like SGLT2 inhibitors, is likely to play a foundational role across the spectrum of kidney disease.
You address chronic kidney disease with, without diabetes, different etiologies. So this is very much covered, so that can cover all the clinical areas that nephrologists are actually taking care of. So there are heterogeneous etiologies, but which patients groups did you demonstrate to have the most pronounced therapeutic benefits for non-steroidal MRAs?
Yeah, so I think what we demonstrated was that finerenone reduces, like you said, kidney outcomes, cardiovascular outcomes, mortality outcomes. But the key question is, who benefits most in absolute terms? One of the things we've learned from these studies is that some patients have higher risks, competing risks of cardiovascular disease. And if you look at the data from Infinity, in patients with diabetes and kidney disease, diabetes is a really strong driver of cardiovascular risk. And so the absolute benefits for cardiovascular and mortality prevention are larger in patients with diabetes. They're still present in non-diabetic kidney disease, but the absolute benefits are bigger in people with diabetes. And I think that is important to recognize because most people with diabetes and CKD will die before they reach kidney failure, predominantly due to cardiovascular disease. And we can modify that risk now with finerenone. In terms of the glomerular disease data in who might benefit most from treatment, certainly the data suggests that the effects were consistent across glomerular diseases. One of the interesting subgroups of interest was FSGS because perhaps the effect was most pronounced in those individuals. And it's worth recognizing that the mineralocorticoid receptor is expressed on podocytes. And we know that MR overactivation drives podocyte injury. And so I think this is a particular group that's worth studying in greater detail. And we hope to do that in the future.
Yeah, definitely. So it means a lot.
Absolutely.
If you are at a higher risk, then you will get more benefit. And it is important not only for physicians, it is important for the patients, for the future, for their quality of life. So now let's address steroidal versus non-steroidal MRAs in non-diabetic kidney disease population. So how does finerenone differ from spironolactone?
Yeah, so good question. I think it's the elephant in the room often, and it's worth addressing. When we look at the data for spironolactone and other steroidal MRAs in CKD, let's look, what do we have to guide our practice? Well, the largest trial conducted with a steroidal MRA in CKD was BARAC-D. This enrolled about 1,500 patients with CKD to assess cardiovascular outcomes and rate of GFR decline in these patients compared to placebo. And what the trial found was that 2/3 of patients allocated to spironolactone discontinued treatment due to protocolized safety issues. And that's very different to what we saw in FINE-CKD and indeed in Fidelio and Figaro. So I think one of the key things that study points out is the issues related to safety and tolerability. And outside of that, the data for spironolactone and eplerenone in CKD is largely limited to small trials with inconsistent results and only modest effects on albuminuria that are inconsistent across studies. So certainly, as it stands at the moment, the data are much stronger for the non-steroidal MRAs. So many of our listeners will have heard of aldosterone synthase inhibitors, which are emerging as another therapeutic class of agents that also focus on the aldosterone axis. How do they work, and tell us about those trials that are ongoing at the moment?
So, thank you, Brandon. We are actually living in a honeymoon for nephrologists. We've got a lot of data from finerenone, but we've got also more data coming from aldosterone synthase inhibitors. Why? Because we are going upstream. That means we are going to see what happens when we inhibit aldosterone synthase in the glomerulosa in the adrenal gland. So if we decrease aldosterone synthesis, we will be able also, of course, to decrease inflammation, to decrease podocyte inflammation, to decrease albuminuria, and to decrease all this tubular injury, glomerular injury that is coming with albuminuria and decreasing end-stage kidney disease, but also decreasing hypertension. So nowadays, we've got 3 ongoing trials. One is fight hypertension that will go and lead baxdrostat in chronic kidney disease and uncontrolled hypertension, because these drugs can decrease blood pressure. We've got Baxduo Arctic, Baxduo Pacific. This is baxdrostat with dapagliflozin. This is a phase 3 trial. And the third one is Easy-Kidney, and it is vicadrostat plus a standard of care, means vicadrostat and empagliflozin.
Sounds great.
Yeah.
And another class of agent that we've seen data from here at the ERA Congress is endothelin receptor antagonists. So tell us a little bit about endothelin receptor antagonists and what their potential role might be.
Okay, we've got the endothelin receptor antagonist. It is a little bit tricky because endothelin receptors got two parts, ETA, ETB. So one is leading to decrease albuminuria, decrease inflammation, but the other one increases a little bit of fluids. But what happens is that zibotentan, which is the phase 3 trial, Zibo-Dapa combines zibotentan and dapagliflozin. So I think this will lead to results in 2027 because it's a phase 3 trials, and we will see the results. But in terms of inflammation, blocking the endothelin receptor means blocking downstream the NF-kappa B, blocking inflammatory cytokines. So that means that will be like another tool on top of what we already have, on top of finerenone, on top of SGLT2s, and of course on top of RAS inhibitors. And there's another drug, atrasentan, that will lead to results in IgA nephropathy population. So it is not a specific IgA nephropathy drug. It is a chronic kidney disease drug. That means a lot for people living with IgA because it is another tool for decreasing albuminuria. And decreasing albuminuria means decreasing inflammation, means decreasing podocyte injury, tubular injury, and end-stage chronic kidney disease, definitely. So, Brandon, what do you think it's going to happen in the future? Are we going to use all the things? We are going to select population? We are going to address different phenotypes? What are your thoughts about the future?
I think from a high-level perspective, we're moving towards an approach of combination therapy as a new standard of care. And we know that's important because, as we said, and as you said right at the start of today, Beatrix, there are lots of different mechanisms of disease progression, and we need to target each of them if we're going to achieve the optimal outcome. In diabetic kidney disease, we have 4 proven therapies to reduce kidney failure and cardiovascular risk: RAS inhibition, SGLT2 inhibitors, non-steroidal MRAs, and GLP-1 receptor agonists. In non-diabetic kidney disease, we've had RAS inhibitors and SGLT2 inhibitors, and now we've got non-steroidal MRAs. So our pillars of therapy are expanding for non-diabetic kidney disease, and perhaps in the future we'll have additional treatments too. One of the unique aspects of the management of non-diabetic kidney disease is we really also need to address the underlying cause of the kidney disease. We now have disease-specific, or will soon have disease-specific treatments for some immunological kidney diseases, particularly IgA nephropathy. And we need to address both issues, the immunological basis of the disease, as well as the consequences of ongoing nephron loss. And so I think we are moving towards a world where we have a multifactorial approach to CKD management with etiology-specific as well as etiology-agnostic therapies to reduce the risk of kidney failure. And as you say, patients at the highest risk benefit most in absolute terms, and we really need to do a better job in identifying those high-risk individuals, treating them early and aggressively to preserve their lifetime kidney function and reduce their lifetime risk of kidney failure. Beatrix, what are you most excited about with all of these therapies now and after the last few days at the ERA Congress in Glasgow?
I think the most important thing here is the patient care, the patient-centered care. If I can go tomorrow to my outpatient clinic and sit down in front of someone after ERA meeting, after all the high-impact clinical trials, it is like I can say to my patient, there is a future here. There are a bunch of opportunities here for you to get a better life.
So thank you for participating in this activity. My name is Brendan Nguyen, and I've really enjoyed our conversation today, Beatrix, so thank you for joining me. Please continue on to answer the questions that follow to complete the evaluation.
This program was presented by Medscape Education Global.